Good evening, Endo Summit Live, and welcome to the next in our series about your journey with endometriosis. Tonight, let's talk about sex. Painful sex is a medical condition, and it is not something you have to just live with or ignore. There's nothing wrong with you, and there is something you can do about it. And I have amazing guests tonight to talk about that with everybody. Please welcome our physical therapist and more, Dr. Juan Michelle. And can you introduce yourself?
Yeah, so I'm Dr. Joanne Michelle Morton. I also go by Dr. J. I am a pelvic floor therapist and a sex counselor in the Atlanta metro area, and the owner of JMM Health Solutions. My practice specializes in pelvic, perinatal, and sexual health. And so just an honor to be here tonight with you ladies.
We are so excited to have you and you ahead of your presentation during Endo Summit surgery, which will be amazing. Please also welcome Dr. Allison Shikandi, a physiatrist specializing and changing the world of pelvic pain. Dr. Shikandi, can you introduce yourself?
Sure. My name is Allison Shrikande. I am the co-founder of Pelvic Rehabilitation Medicine, and we take care of women with chronic pelvic pain, pelvic floor muscle dysfunction. We are a national women's health platform, and I'd say the majority of our patients have endometriosis. So that's our love, our passion is really helping patients with endo and talking about intercourse and sex all day. So thanks for having me.
Yes, talking about sex all day. That seems to be what we're doing best here at the Endometriosis Summit. Dr. Marjorie Mamsang is also joining us. Can you introduce yourself?
Yes, hi. Thank you for the welcome. My name is Dr. Marjorie Mamsang. I also work with Dr. Allison Shikande at Pelvic Rehabilitation Medicine. I love what I do there. I love helping these women out. I also have a fellowship in sports medicine and I teach yoga.
Wonderful. It's so funny. 3 out of 4 of us all started in the sports medicine background. How do you think that, let's just throw it out there because I think the pelvis is very orthopedic. Mm-hmm. Dr. J, how do you think that inspired your connection to pelvic pain that you started in that world?
I think it was a benefit and a blessing because we, a lot of the time we want to pigeonhole things and we say, oh, pelvic health. So it's just pee, poop, sex, and that kind of stuff. But then we don't realize that a lot of our athletes are also dealing with these things. And when we think about performance, when we think about sport specific training, when we think about postpartum athletes, there's so many things to consider. And all these women are dealing with sometimes some form of pelvic floor dysfunction that needs to be helped as well. So.
Yeah, when I made the switch from athletics to pelvis, it was because I didn't want to just fix someone to have them go get hurt again. I wanted to be a part of a journey in their life. Dr. Marjorie, how do you look at sort of healing from sex as almost like treating an athlete? Because it's multidisciplinary the way we would treat an athlete.
Yep. So you would definitely treat the neuromuscular skeletal system, just like how you treat any other injury in sports medicine. But you also think of athletes, it doesn't just affect their performance, but also this is what they love and they do. So it affects their the biopsychosocial aspect as well. And so you have to deal with that aspect as well. And especially when it comes to sex and intercourse, you also have to kind of give patients the resources that it's not just, we're just going to try to work on your muscle spasticity and your nerves to calm them down, but also talk about that piece, that mental aspect as well.
Yeah. So Dr. Shikande, somebody comes to your office or any of your offices nationwide, you have an extensive checklist. So let's talk about where you begin if somebody comes to you. And you did say, you treat women with pelvic pain, but first of all, it's people with pelvic pain, but you treat anybody of any gender or no gender at all, because I've been in your clinics and I know that everybody is trained to do that. So how do you start the evaluation? Someone comes to your office and they're talking about painful sex.
Yeah, the first is a history and really just getting the story. That's honestly the most important part of it all. And a lot of it is just timing, really trying to see when it started, how long it has it been going on for, and was there any sort of inciting event? And then, so story around when they first started noticing. And one thing we also like to ask is, do you have any pain with speculum exams or tampons before you even had intercourse, perhaps, just to help us understand how long it's really been going on. And then really getting a deeper understanding of, is it superficial? Is it deep? Is it what positions hurt? Sometimes it's just one or two, or sometimes it's all positions. Are you able to have intercourse? So really understanding the specificities of their pain with intercourse. Is it post-intercourse soreness, and then what happens? Does it flare your bladder? Do you have lower abdominal pain? Really understanding how they feel during it. And then talking about their libido and where they are in their, depends on where they are in their journey, and in their women's cycle of life, will help kind of tailor it to the hormonal components of what could be going on. And also talk about orgasm, because we see with pain and discomfort a lot of concomitant anorgasmia.
Yeah, we saw a lot of questions today about pain during orgasm, pain after orgasm, anorgasmia. We're going to get to all that later. But Dr. J, let's talk about your evaluation, because you're looking probably at the pelvis a little bit different than everybody else. Talk to me about your evaluation.
So I think my evaluation is twofold. I'm looking at it both as a pelvic floor therapist and as a sex counselor. So really trying to get a comprehensive idea as to what's going on. How is it affecting them? Like, what is your level of bother? Because I really do have some people that come into the office and say, I have pain with sex, but my solution is I don't have sex, right? And for some of them, that's okay, and that's a great solution. For others, then that starts to creep into the relationship dynamic and things of that sort. So it's really trying to, like Dr. Allison said, trying to get a really comprehensive idea as to what is going on, when it started, all those things. I'm looking at them from a neurological perspective, because we know that there are a lot of nerves that could be involved. I'm looking at them from a musculoskeletal perspective, and also even externally, things like the abdominal wall. Do we have tenderness? Are we having like other types of orthopedic association? Are you having hip pain? Because sometimes it might just be, well, what are you having sex with? And I'm like, well, I can't get into this position. And sometimes we know with a lot of persons with endo that are having hip pain, it could be just even discomfort with positioning. And so they're limited there. And then it's looking at that pelvic floor assessment. A lot of times, we may not even be able to do that internal assessment very early on, whether it's because of apprehension and pain, or whether it's because they're just not ready, right? That level of anxiety. And so I usually will kind of guide people into expectations. Here's what to expect. And when you are ready, that is something that we will touch on. But here are some things that we can work on. In the meantime, here are some resources that we can take care of, that we can utilize. And when we are able to perform the internal exam, then we're looking at what's going on with those muscles. Where exactly is this pain? Is it superficial? Is it deep? Are there certain areas that are seeming to trigger more of this pain? All those types of things.
Excellent. And Dr. Marjorie, do you want to take a stab at why endometriosis might cause pain? I don't, Dr. Vidali and I, big surprise coming up, but he's running around trying to finish what I couldn't finish today. Do you want to take a stab at why endometriosis might cause painful sex?
Yes. So endometriosis, so just a quick recap, it's when you have inflammatory tissue that's progressive and growing, and it's tissue that's similar to the inside of the uterus, but it grows outside. So it can grow very nearby to the pelvic floor muscles, which are penetrated during penetrative sex. And even though they're separate, the inflammation can cause a lot of hypertonicity in the pelvic floor muscles and can cause a lot of neurogenic inflammation affecting the nerves, lots of inflammation on the nerves. So that can cause pain.
Yes. So also I like to say, so it'll be very, I always forget to do the definition. It'll be very interesting at this upcoming endometriosis summit. Dr. Redwine will be presenting why the definition of endometriosis really should be changed. So that'll be very, very cool. But I also think that if endometriosis is in the rectovaginal septum, which is a common site for endometriosis to be laid down in, then any type of penetration that hits the rectovaginal septum or hits the cervix is going to cause pain. And that doesn't necessarily, and that typically is pain further back. However, which I learned in this series the first week with Dr. Mawad, that pain, that if endometriosis is within 3 centimeters of a nerve bundle, it can trigger pain down the whole length of the nerves. And we know that endometriosis loves to be around in that rectovaginal septum, which interferes with the sacral nerves, with the hypogastric plexus. So you could have pain from sex in a lot of ways. So I think we don't often, and I'm so excited because I haven't had any of my toys since I moved, but we don't often, I don't know that anybody, we assume, because we live in this world, that everybody knows what this is and what the pelvic floor is. Dr. J, do you want to explain to our viewers out there who may not be sitting at their dining room table with a pelvis like I am?
Yeah, so the pelvic floor is a group of muscles. They run from front to back. So think pubic bone, right, which would be up at the top there, to the tailbone all the way back. And they act like a hammock, if you will. I like to tell people, think of yourself just chilling at the beach. You're in a hammock, you know, you got 2 trees, your pubic bone and your tailbone, and the pelvic floor muscles are the hammock, right? And they tend to do a lot of things, including support the organs, stabilize the pelvis to prepare for movement. They help with sexual appreciation, especially those superficial muscles that help a lot with engorgement, which is why if we've got nerve irritation, if we've got tissue irritation, we can have pain with sex as well. And they keep you dry, so keep pee and poop off the floor. So we've got the superficial muscles right here. You can see what we call the urogenital triangle, right? So we've got 3 important muscles: ischial cavernosus, the superficial transverse perineum, and then we've got the bulbous spongiosus right there around the opening and right by the labia, which also kind of sits above the clitoris, because we don't think of the clitoris a lot, but the clitoris is very deep and very large under this muscular tissue. So again, too, if we've got a lot of hypertonicity, we've got some tight muscles, then the clitoris can be affected. We can have some clitoral pain. We can have some pain with orgasm. We can have some pain with arousal and engorgement and all of those things. And then in addition to that, we've got those muscles kind of closer to the anus right there, which are the deeper muscles of the pelvic floor. So they help a lot with support. But oftentimes, again, if these muscles are tight, then we're going to also see a lot of pain there. We might be having some pain in the hip. If the obturator internus is affected, we may be having some pain further back with the rectal muscles, defecation, pouch of Douglas, so that rectal vaginal area as well. So those muscles tend to be very, very involved in sexual dysfunction.
So
That's
Dr.
a quick and dirty.
Yeah, I wanted to tell you, I forgot to warn you, there was gonna be a quiz and you were gonna have, you did amazing. Thank you. So Dr. Marjorie, in your practice, what can you guys do for the pelvic floor pain that might be different from what Dr. J can do?
Sure. So for pelvic floor pain, so many women have had their symptoms ongoing for many years, especially if they have a history of endometriosis. They've had cyclical dysmenorrhea. So it's been spastic for a long time. And sometimes they need, even if they have an amazing pelvic floor physical therapist like Dr. James, sometimes they just need other things on board. So medications can help, medications specifically in suppository form, a combination of muscle relaxers, but also sometimes like neuropathic pain medications, like such as gabapentin, to be used either rectally or vaginally. And what's great about it is if you use it rectally, maybe 1 or 2 hours before vaginal intercourse, it doesn't tend to come out, and it may relax your muscles a little bit more prior to vaginal intercourse. So that's something that you can do.
Yeah. Now, how do you talk to a patient about Because sometimes people who have a lot of pelvic pain don't have the greatest relationship with their bodies, and they
Mhm.
might have some trepidation.
Mhm.
And that in itself may lead to a little bit of medical trauma. So how do you talk to someone about using a suppository, particularly rectally? Because I don't think women are used to sticking things in there.
Great. So actually, what I found is women with vaginismus or a great fear of any vaginal penetration, they are actually like more open to using it rectally than they are vaginally, just because that's been like a big no area for a long time. And then rectally, I kind of tell them, so it's one of those things that in plain words, I just say it's one of those things, it's weird in the beginning, but once you get used to it, it will get better. And when you place it in, you can simply just use one finger, or you can use an applicator, which the compounding pharmacy sometimes gives you. And you place it in maybe 1 inch deep. But once you place it in, you shouldn't feel anything at all. And that's when you know you place it in far enough. If you place it in too close, like too close to the rectal opening, it might make you feel like you might have to go poop. So that means that you just didn't push it far enough, and it's okay. If the first couple times that it comes out because you didn't push it far enough, it's fine, but it just takes a little bit of practice. And then also, I would also tell them the pelvic floor therapist usually teaches you muscle relaxation techniques that they can do right before they place in the suppository.
Yes. Now, Dr. J, which I totally forgot you were sex counselor also. So I'm so excited to have you. What I think it's an important conversation to have when you talk to somebody about maybe needing suppositories, or we didn't even get to dilators, or needing a pelvic wand. People feel like maybe they did something wrong, or they have to do an extra step. What are sort of the things that you communicate with them to really as part of trauma and informed care? Because it's not about that you did something wrong, so now you have to go through this experience of sticking in a suppository.
Yeah. So the biggest thing is, like you said, really helping them to understand that they're not at fault here. Surprisingly, a lot of people come into my office not diagnosed with endo, but their primary complaint is dyspareunia. And then by the time we get through the workup, and I'm like, I think you should go see this person. Come to find out, like they're very, have all the findings that are consistent with endo. But what I usually am telling them is your body is really amazing. And that's usually how I start off. And think of it like a really good home alarm system. And so when everything is functioning well and Sparky the puppy is walking around the house, nothing goes off. But when your body is very heightened, when there's a lot of inflammation, when there's a lot of stress on the tissues and the body and on the nerves, it's kind of like the leaves are blowing outside and the alarm is going off. Sparky's walking in the house and the alarms are going off. And it shouldn't be. Your alarm should only be going off if a burglar was trying to get into the house. And so we really have to work on calming the system down. And so some of these medications can be very helpful in just allowing your body to be calm and giving your body the opportunity then to start to heal. And so I think sometimes just explaining that to them in a way that they can understand and that resonates with them is helpful, so that they're not doing the blame game, which is very, very common because, in committed relationships as well, they're sometimes already being blamed by the partner. Well, something is wrong with you. What's going on? Well, why is it like this? Well, I never had a partner like this, and all these different things. So they're oftentimes feeling a lot of stress. And we know that there's nothing that they have done, but it's really trying to frame things in a way to help them understand your body just needs a little bit of help right now. It's nothing that you've done. There's nothing wrong with your body. You are perfectly fine. We just want to give your body the help and nurturing that it needs to help you heal and be the best that you can be.
I love everything that you just said. I just do. Wonderful. Dr. Shikandi, what role do the nerves play around painful sex? And maybe even some nerves people don't normally connect to the pelvic floor and endometriosis. And endometriosis, everybody likes to talk about the hypogastric plexus and the sciatic nerve, but I think that there's a lot more nerves that play a role here.
Yeah, no, 100%. As Marjorie had mentioned earlier, with endometriosis, there is a lot of inflammation in general. It's a systemic inflammatory disease process, but particularly around the nerves. And we are looking at the different peripheral nerves of the pelvis. The common ones would be the pudendal nerve, right, involved with intercourse, probably the main nerve that's involved with intercourse, both sensory and motor, getting the muscles functioning well, as well as with sensation of either positive or negative. And then the pudendal nerve has three main branches that it's important to take a look at as well. There's the inferior rectal branch that comes off and goes right to the rectum. There's the perineal branch that goes to the perineum. And then there's that dorsal nerve to the clitoris that goes up the ischial, little pelvis, and goes behind that pubic bone. So those are kind of the branches of the pudendal that are all super important and all involved in their own way with intercourse and then pain. And then there's something called the posterior femoral cutaneous nerve, which is a nerve that runs right next to that pudendal. And there's a lot of, we call it crosstalk between those two nerves. So cross innervation. So they kind of are best friends and they work together, good or bad, but they are closely related and also involved with intercourse. And then there's the ilioinguinal nerve as well, which comes from above. And we say it's the upper 1/3. And then there's the genital branch of the genital femoral. So those two are coming from above in the abdomen, going down into the pelvis. And the other ones are coming from the lumbar sacral plexus and then going more wrapping around. So
Go ahead.
Yeah, so all those nerves are work together and are all involved with intercourse.
I always like to remind people that the nerves you just described, if somebody complains of itching in the pelvis, we should be thinking about the nerves, right, Dr. Shrikande?
Yeah, no, that's very common. Itching is one of the more common for nerve pain is itching. So that it feels like an annoying yeast infection. Sometimes they'll say that just they never goes away, or they've taken, all these either topical, oral antifungals, and it's still itching. Yeah, nerve and itching is super common. And I always explain it's like when you're a little kid and you got a cut and you are healing, and sometimes when that cut is healing, it can get itchy, that itchy sensation, and that's nerves. That's the nerve healing. So it's a similar thought process to having them understand why itching would be, nerve.
Yeah, and I think it's something that's really important because what happens is to have it evaluated, because you go to the regular gynecologist and you say, I itch, and most GYNs will just hand you yeast infection, whether it's oral or a cream. What does that do to not only the vaginal microbiome, but to the overall gut microbiome?
Exactly. Yeah. Excessive amounts. When particularly the main issue is when there's no confirmed really diagnosis of a yeast infection or any sort of infection, and you're given topicals or orals. So it's going to alter the local pH, definitely the microbiome of the tissue, the vaginal tissue, as well as your gut. It can alter the pH there too and make it so that you're more predisposed to SIBO, so small intestine bacterial overgrowth, when you have recurrent treatment with antifungals or antibiotics there was no diagnosis.
Yeah, I mean, there's also all sorts of literature that changing the microbiome is going to change even the way your body loses or gains weight, that it impacts implantation if you're seeking fertility. There's lots of things that goes on. So I wish everybody could have that evaluated instead of just immediately going to the yeast infection. I wonder, we talked about it last week, but Dr. Marjorie, what role does the central nervous system play in painful sex?
Great. So when someone has had any kind of chronic pain longer than 3 to 6 months, the central nervous system gets upregulated. It's called central sensitization. Basically, the way that your brain, I explain to patients, the way that your brain is perceiving the pain and it receives those pain signals, it becomes more amplified because there's more receptors that are activated and your threshold for pain lowers. So that's a good example of that is when you're doing maybe the Q-tip test, or maybe you're barely touching the patient, but they're like jumping off of the table. That's because their central nervous system is kicked up. So things that help with that naturally is meditation and movement meditation like yoga. And then also sometimes, especially with women who's had their pain for years, endometriosis background, maybe an oral like CNS or central nervous system neuromodulator, just for short term, even just to down regulate everything.
Yes, very interesting. So, Dr. J, how do you approach, first of all, what is anticipatory pain? And how do you approach working with someone who has anticipatory pain with sex?
The thing about that, like Dr. Marjorie just said, their body has been so wired for so long that everything hurts. I usually joke with a lot of my patients and say, it's to the point where you probably know the look that your spouse is giving you. And that look means that they want some. And then you start running because your whole body starts hurting because you're like, no, because that's going to hurt. They haven't even touched you yet. But it gets to that point sometimes, and you do everything to avoid it. And so in approaching that, what I start to do is desensitize them to a lot of things, even externally. Like you mentioned earlier, there are a lot of people that have a lot of issues when they've had painful sex. They have a lot of body issues. And so sometimes we might need to start with just fully clothed and just doing some tactile, just put your hands on your arms, put your hands on your abdomen, put your hands on your legs, just so that they can recognize this is a non-threatening, non-painful stimulus. You are not in any, danger. This is not going to hurt, so that they know they're okay. And we can start retraining those neural pathways so that the brain acknowledges, oh, wait, this is okay. And even with the partners, can my partner touch my thigh and me not jump and start walking on the ceiling? Just again, so that we have that association, that positive association. And as they can tolerate those things, start maybe taking layers off, because for some people, it may be fully clothed. For other people, it may be, then let's start peeling some layers off. Let's start acknowledging our body. Are we getting anxious just being naked? Right? Because again, being naked for a lot of people, that's their only association with sex. It's like, oh my God, if I'm getting naked, something is about to happen. So really trying to create positive associations for these individuals, even before we get to things like the dilators and the pelvic wands, because that in and of itself is going to create crazy anxiety and might create a lot of non-compliance. Like you might think that this person is just being non-compliant, and it's really not that. They're fearful. And so we want to make sure that we take that away, again, by creating those positive associations for them. And a lot of what I do with a lot of these clients is starting to transition from being okay with my body. Can I look in a mirror? Can I touch my body? Non-sexual touch. Can I touch my body? Does it bother me? Am I afraid? Am I nervous? Am I anxious? And then going from there into things like sensate focus, where they could do it solo or even partnered, where sex is off the table. So there's no worry about, oh my God, this is going to lead to sex. So that pressure now is removed, and they could start to create those positive associations.
I think I have Dr. J's workshop planned for next year. While it's like great. I can't wait. So I wonder, Dr. Allison, if somebody has endometriosis and their primary complaint is painful sex, remove the endometriosis first, or what would you do?
Known endo? It's a pathology.
Well, let's say there's somebody whose gynecologist said, I think you have this, so here's some birth control pills. Let's do that. Let's do that scenario. What would you do?
Suspicion of endo. It's a discussion with the patient usually, typically, and history, physical. Your thoughts on if you're, in agreement that you have high suspicion for endo based on the history and exam. And then you kind of present the options to the patient, really, is what we typically would do. How are they feeling? Because it's such a spectrum of disease. So it just depends on how their quality of life is, right? How are they functioning? Are they going to work? Are they not just going to work? Are they present at work? Are they able to go to social functions? And are they able to have intercourse? Are they sleeping, exercising? So a lot of it's about the individual and how it's affecting their life. and then presenting them with different options and going from there. So it's not so black and white. I think it really just depends on the patient. But
I love that, I love that term. It's not so black and white. It really depends very much on the patient. And I think sometimes we don't, certainly if you're going to go the surgical route, we encourage excision. But it should be your decision as a patient, which is why we do so much on informed consent. I wonder, okay, so the person has had surgery, and Dr. Marjorie, they are now, it's 6 weeks post-op, perhaps they're trying to conceive, perhaps and they want to get back at it. But they're nervous. What do you talk to them about? How do you navigate that with them?
So I meet a lot of patients who are post-op, very good endometriosis excision, and I'm meeting them for the first time, and they're very confused because they still have a lot of their symptoms, or they still have especially painful sex. And so they are nervous, like what you're saying. And what I say is your endometriosis is out. They've removed that tissue, but for many years before that, you've had all of this hypertonicity buildup and the neurogenic inflammation. So now we just have to deal with that. We just need to downtrain that hypertonicity and calm down some of that neurogenic inflammation. And then at Pelvic Rehabilitation Medicine, we have an injection procedure protocol to help with that, but then also medications as well. But it's all of the years of hypertonicity and the neurogenic inflammation that we just need to now down-regulate. A lot of people want like a quick fix. They think, I just need this surgery and that's it. But really, things have been brewing for a long time. So it doesn't mean that we're never going to get to that 100%. You'll get there. We just have to give it some time. It's kind of just like how you were saying with athletes, like when they get an injury, sometimes athletes are just like, oh, I just need to do this, a few PT sessions, and then I'm back in the game. That's usually not how it goes. There's a stepwise progression, and then you slowly get back into the game. So it's very discouraging sometimes because their patients are like, I'm already doing this and this and this, but still it's a little bit painful. And throughout the rehabilitation process, you just have to remind them that there's ups and downs, and that's normal, but you'll get there little by little.
Right. So top question, when we asked viewers lots, top question was, I had excision and I still have pain. Why? So now we answered that. Another one of our questions was pain with orgasm. Let's unpack that. We'll start with you, Dr. J.
So like I mentioned, when we think about orgasm, we think about all that blood flow. We think about that heightened response to that peak arousal. What's happening? We have tightening of those muscles. Well, if the muscles are already tight and the nerves are already irritated, and now we're getting a little bit more of that, maybe some spasming, that's what can cause that pain with orgasm, especially when we're having clitoral orgasms too. People think the clitoris is just what they see right by the hood and don't realize that there's a whole lot more under the hood.
So, I know. I don't have my 3D model in this box. I wish we'll show one sometime on an Instagram, and maybe you'll come back and join us for an Instagram live. But I was a pelvic PT, and it wasn't until 3D printers came into the game that I realized how big the clitoris is.
Mm-hmm. And when it gets engorged, it gets even bigger. And so now think about those muscles, especially those superficial pelvic floor muscles, really becoming engorged and really tightening now on that already irritated area, because we've got the dorsal nerve to the clitoris, right? That pudendal nerve branch. We've got other things going on in the area. And so now we're having pain. So I think a lot of it is helping to educate people with regards to pain with orgasm, and also even teaching a couple of techniques. So if I'm having pain with arousal, because for a lot of people, they're very performance focused. And I tell people a lot of the time we're having pain with sex. Sex is about pleasure and the journey. It's not necessarily always about the destination. You orgasm and the sex lasts like 2 minutes, or you could have somebody and they orgasm and you're still there waiting like, okay, It's going to come one day, right? So it's really about pleasure. And if we kind of switch to a pleasure focused dynamic, I think that is a lot more helpful for some people. We can also start then to look at techniques that can kind of increase and heighten pleasure, where we're getting to the brink of maybe an orgasm so it's not as excruciating, and then backing off a little bit. So something like edging that we can utilize with patients, when they're working with maybe a sex therapist or a sex counselor, to kind of help them and their partner to really hone in on those particular things.
Yeah, I think also we talk about the pudendal nerve, but as somebody who does a lot of clinical work in hernia, when that clitoris engorges and runs alongside where the ilioinguinal nerve innervates, you can get a tremendous amount of pain. And from a PT perspective, that sometimes can be changed by a position that is not necessarily compressing that nerve.
Absolutely.
Dr. Shrikandi, you alluded to it in the intro, but let's talk about anorgasmia. Let's talk about it. Let's talk about all this that no one wants to talk about. The four of us should just talk about it.
Yeah, no, I mean, anorgasmia is extremely common, right? Particularly when you're having pain around intercourse, it comes often together. And honestly, in our world, it is easier for us to make the pain go away. It happens faster, right? To really calm down that spastic pelvic floor, both deep and superficial, calm down the inflammation around the nerves, increase blood flow, and allow them to heal. But really the anorgasmia comes later, and it really comes with the whole rehab process, right? Because you have to first downtrain, as we've been saying, and release and calm the inflammation. But then after that, you need that neuromuscular re-education process. And that's when the nerves and the muscles of the pelvis start to fire together. Everything starts to, you're not having the pain anymore. And then you do start to get your orgasms back, but it is really a rehab process where you're resetting, retraining, getting everything working again to function and for pleasure, right? Really, it is that whole mind, body, soul connection too, letting yourself trust yourself that doesn't hurt anymore. And that needs to occur, I think, too, before you can get your orgasms back. Trust your body, start to enjoy, and then keep at it. And they do come back. They do. That rehab really does work. It takes a little longer, I think, for the orgasm piece than it does for the pain piece.
I know we talk about endometriosis, but just let's chat about adenomyosis for a little bit. So adenomyosis, very oversimplified, is endometriosis lodged in the walls of the uterus. And so, lots to unpack. Maybe we should come back and let's talk about sex and adenomyosis during April. We should come back and do that. But I'm going to ask a quick question now, because April is Adenomyosis Awareness Month. And a lot of people with adenomyosis have pain during orgasm. Dr. Marjorie, why might that be?
So kind of what Dr. Shrikandi was saying earlier about the nerves, and one of the main nerves in the pelvic floor that's affiliated with sex is the pudendal nerve. And the pudendal nerve for women, for sexual activity, it also helps with orgasm or climax. And so if the nerve is already irritated, and then anytime you have any sexual activity or you're using that nerve is firing up. And if it's already irritated, it can cause some pain afterwards.
Yeah, I think with adenomyosis, there's a lot of discussion about, does the uterus contract during orgasm, and is it causing pain on the organ that has the disease on it? Does anyone have an opinion on that?
I mean, with one of the things to also consider is, with adenomyosis and just where people are sensing pain, if they're having any type of dyspareunia and we're hitting that cervix with deep penetration, we're also still going to have a lot of pain with that. We're looking at all the different nerves involved, even the pelvic nerve, and just all of the inflammation that may be in that area. So there's a lot to kind of unpack with that. I mean, and just even think about, okay, if this is what's going on, what can we do? Positioning and, ONA and different resources that we can, similar to endo, that we can utilize for those individuals as well. But oftentimes with that deep dyspareunia, with that cervical impact, they're going to also feel a lot of discomfort.
Yeah, I think also there's the conversation, and maybe we'll come back in April and talk about this, of uterine orgasm versus clitoral orgasm. Any commentary on that? Anybody? Go ahead, Dr. J. I know you got something for us.
I mean, I think when people think of orgasm, they just like everybody thinks of clitoral orgasms, and they don't realize and recognize that uterus is a muscle too. And with stimulation, we're going to have the same contraction. If we've already got inflammation and irritation there, then it only, stands to reason we're going to have that can elicit some pain for these individuals as well. So again, kind of thinking back to, there's cervical orgasms, there's, uterine orgasms, there's clitoral orgasms. And, potentially there are some orgasms for people with overly stimulated the pelvic floor muscles as well. And so just kind of thinking of all of that together, helping people to understand that when they're thinking about orgasm, when they're thinking about sex, this is not a one size fits all. There are some people for whom, that stimulation with deep penetration is going to elicit that pleasurable sensation. And for some people, it might just be that superficial, more external stimulation at the clitoris, right? We know 70% of women will orgasm with clitoral stimulation only. So for those 30% of women who are stimulated with vaginal penetration, those may be your people who are having those uterine and cervical orgasms. And for those people, they may be having an intense pain with that.
Yeah.
Yeah,
So
I
go
agree.
ahead,
Yeah, I mean, if nicely stated, because the uterus is a muscle. And so within that muscle wall, if you're having the endometrial-like tissue, which is inflamed, and you're contracting over that, then it would make sense that you're going to have some pain when you're orgasming, if a deep uterine pain. But from my experience, it's a different sensation when you have that sort of deep uterine spasm pain with adenomyosis versus the clitoral stimulation pain with orgasm. So it's really a different kind of a deeper sensation that's usually harder to localize. And then also, I think with adenomyosis and pain with orgasm, there is an effect on the autonomic nervous system as well, that you get versus having pain on the clitoral stimulation aspect.
do you feel that those are the people who that adenomyosis and that autonomic component, that may be the person who swells a lot after sex? They have a lot of endobelly post coitus, I guess. If you're a Big Bang Theory fan, post-coitus.
And some rectal pain too, I find, with those people that end up talking about like those rectal spasms even after intercourse as well.
Yeah, so we have a question coming off of Facebook. What role does a lot of uterine questions. What is the role of an inverted uterus with painful sex? And we know that an inverted uterus oftentimes in endometriosis is happening because the endometriosis in the rectovaginal septum is pulling the uterus back. But Dr. Marjorie, any thoughts on the role of an inverted uterus in painful sex?
Yeah, I think that just like with any of the other symptoms, when the uterus is inverted, the pelvic floor there's compensatory patterns that are involved. So pelvic floor muscles are a little bit more hypertonic. So that's one of the causes for painful sex.
Very interesting. I don't think I ever put that together, that the floor was going to compensate, just like the floor is going to compensate if you're feet pronate or supinate, or I don't know. Yeah. With painful sex, I think a lot of what can you do to help the person facilitate conversation with partners?
We bring our partners in the office if the patient's open to it. That's one, I think, always a positive sign if both are willing to have them in the room. And then working closely with desensitizing each other and doing a lot of times the home program given by pelvic floor physical therapy together, and asking for help with the home program, I think, is a nice way to start like a gentle intimacy. Again, I like what you're saying, Dr. J, but sex is off the table. It's more just, it's more of a subtle touch and help each other out in more of a supportive manner.
Dr. J, another common thing that we had comments on today was, so many are told, first of all, penetration is not always the destination, but so many are told like this, well, did you try other things? Let's talk about that. Pleasure is the destination, and sort of that statement of try other things. How could it be presented, and what could be the journey there?
Yeah. So, when we think about pleasure, first of all, what does sex look like for them? Right? Because we might, as professionals, get in our mind, oh, they're having sex and sex is painful. But one of the first questions we could ask is, what does sex look like? And they might tell you, oh, well, we have sex in missionary. Well, do you try any other positions? Well, no. Okay. Well, let's start there. And something, as simple as, let's try some other positions. Let's work on exploring. Right? Let's work on exploring each other's bodies. So we take a more a much deeper approach into focusing on the body instead of just focusing on the outcome. Like we're not worrying about, oh, let's just go in there and have an orgasm. That's it. Let's focus on each other's body. What feels good? I always tell my clients, when you're working on touch, you always want to think about, what do I feel? How does this feel to me versus how do I want it to feel? If I touch my partner, how do I feel when I touch them? How do I want them to feel? And now compare that to, how does that actually feel to them? So there's a lot of communication that needs to be involved in sex as well. We also need to think about, what things can we utilize, right? So if we've got a lot of hypertonicity in there, is one of the issues that they're also dealing with some dryness? If so, let's lubricate. If for a lot of persons with endometriosis, their primary complaint is going to be that deep penetration, not just necessarily superficial, although that might be the plight of some. So if we're thinking about deep penetration, let's kind of limit the depth. Let's think of either using something like an O-nut, so some type of barrier to limit penetration. Let's think of position changes. Let's think of sex furniture, because it's really a thing. Let's think of wedges. Let's think of other positions that can limit the depth, using pillows, all types of things. So one, we create a sense of comfort. Two, we create a non-threatening sense there, but we also get an opportunity to try different things and explore what might feel good. I typically tell my clients, listen, what might have felt good to you 10 years ago might not feel good to you now. What might have felt good to you last week might not feel good now. So always kind of constantly explore, because your body is constantly evolving. You're just getting better, and you also want your sex to evolve with you, right? And I discuss that with partners as well, because partners get real excited. Oh, we did this thing and I was good. It's not working this week. Well, it's not you, honey. We just try something different, and I think when we kind of frame it in that way, it also lends itself to a little bit of excitement. So now they have something that they can work on together. And so it's not so much, well, in and out, and then we're good, right? It gives them a little bit more to kind of focus in on.
Wonderful. Doctors, do you have anything to add? Neither of you look.
Yeah,
I think that was great, Al. That was good.
Yeah, in terms of exactly, how you work on it. Yeah, not much more to add there.
All right. So we are coming up on, I believe the count is 25 days away from the Endometriosis Summit 2023. It'll be held in person in Celebration, Florida, but it is also held virtually worldwide. We do have an entire workshop given by Heather Edwards on pleasure and intimacy, which pleasure could also not contain any intimacy at all. But I didn't call it a sex workshop. I called it a pleasure workshop. And I remind you that we are all entitled to pleasure. She was howling. I didn't know what to do with her. So that we are all entitled to pleasure. Even if you have pain, there's a way to heal your body and to interact with your body. So the Endometriosis Summit is coming up March 24th through the 26th. There are tickets available. For some of you, this is your first time you are participating. Dr. Marjorie, what are you looking forward to about the Endometriosis Summit?
Well, there's an event Saturday night, the Below the Belt Talk, hosted actually by PRM. I know I'm a little bit biased, but I am excited for that event.
Right. So PRM, Pelvic Rehabilitative Medicine, is hosting a in-person screening of Below the Belt. It will be outside under the stars. And that is very exciting for me, but it'll be amazing to watch that. And that is provided by you guys. And we are so very grateful. Have you seen the film, Dr. Marjorie?
No, I haven't yet. So I am excited.
Oh, it is technically the Florida premiere, we've been told, but we didn't really, so it'll be exciting. Dr. Shrikande, what are you looking forward to at this year's Endo Summit?
I'm looking forward to just being present in the moment with so many amazing people passionate about a mission and cause that is near and dear to my heart. And it's just always been such a great time just being surrounded by such amazing people, honestly.
Yes, and I'm also looking forward to you guys. We decided that during our raffles, we're going to give away one of your t-shirts, which have a very interesting design. I really can't wait. That's for in person, and people should like get ready to scavenger hunt because that's one of the prizes. Dr. J, this is your first endometriosis summit. Now, we forget to mention that Dr. J practices in one of the best areas to treat endometriosis because she has access to 3 Endometriosis Summit faculty members. You are down the street pretty much from Center for Endometriosis Care with Dr. Cernovo and Dr. Eugenio Colon. And also Ashley Davis, who is in Atlanta as well, who is another excisionist. So I should just mention that you're making Atlanta like this big hubbub. Are you guys also, is there a PRM in Atlanta?
There is a PRM in Atlanta.
Oh my God.
Dr. Taylor, and she is phenomenal.
Atlanta's like the center of the universe for endometriosis care. Yeah. Oh, now I have to meet your doc there. Yeah.
Fantastic,
You love
Dr.
her.
Nikita Taylor. Yeah. And
You would love her. She's the sweetest personality.
All right. Well, we'll work her in for next year. So Dr. J, what are you looking forward to at the endometriosis? Oh, I forgot to put my hat on. What are you looking forward to at the Endometriosis Summit this year?
I am kind of fangirling and excited to meet all the amazing speakers and, providers that are going to be there that, I see on the internet, and I listen to webinars and all those things, and to get to meet them in person and share the space with them is going to be awesome.
Well, we are excited the hats are on sale for in-person participants first. Then afterwards, I'm going to have to figure out this thing called a Shopify account. So by the way, I could take a volunteer if you are one. And the registration is at www.theendometriosissummit.com. I also encourage you to take a look at our Instagram at Endometriosis Summit for this particular week, because we got a big unveiling ready to go with Dr. Vidali and I over the weekend. And I hope to see everybody March 24th through the 26th at the Endometriosis Summit. So next week, we are either talking about HIP with Dr. Bouza and Dr. Zolan, or we're talking about abdominal wall endometriosis. It's sort of up in the air. We're waiting for to see everybody's surgical schedules. But we will be back here next Monday at 8 p.m. with something exciting. Good night, everybody. Thank you. Thank you so much for joining. This was phenomenal. Are we coming back for a adenomyosis awareness month in April? Does everybody want to come back?
Definitely.
Yeah, let's do it.
Yeah. So that'll be
you.
awesome. We'll set that up. But right now, we'll see you next week and at the Endometriosis Summit. Take care, everyone.